I want to get back to some of the new generation techniques for implants, but before I do, I'm going to ask you a little bit of a challenge question about the nipple sparing, and then something that I know is not going to be a challenge for you. Oncologically, the idea that the tumor can't be too close to the nipple areolar complex or multicentric disease, relative, if not an absolute contraindication for nipple sparing mastectomy. You mentioned a great statistic that, we're looking at up to 99% of patients being, and I haven't talked about the reconstructive restrictions, like if somebody has very large ptotic breasts, or if they're an active smoker, or have some other reason for not being able to perfuse their nipples. Can you sort of address all of that at once, right? All of that at once in terms of whether or not there have been changes that have basically made that yesterday's news or not?
Yes, I think everything in surgery is an evolution. And I think it took time for us to understand what needed to be, what could be preserved while having oncological safety. And that was a learning curve. As I mentioned, 25 years ago, the standard was skin sparing mastectomy, which means you spare the skin but remove the nipple. But we realized that really was sometimes overkill. And there was a trend that started with being able to spare the nipple. Now, the nipple does have ducts, as we know, that kind of end in the nipple. And there was controversy to say, if you spare the nipple, are you leaving anything behind? And there was some time that it took for, standards to sort of be developed to say what is safe and what isn't with sparing the nipple. Now we generally say that if the tumor is at least 1 centimeter from the nipple, in our institution, there are others that say 2. So again, there is some debate. But if the tumor is more than 1 to 2 centimeters from the nipple, then the nipple can be safely preserved oncologically. Now, what we do in our center is we also take a biopsy under the
Yeah,
nipple.
that was part of our
So,
standard procedure too. Yeah.
so we always want to double check to make sure that we're all clear in that. And that has been really, really successful for us. We have very, very low recurrence rates. I can think in my head over the course of the, hundreds or thousands of patients I've taken care of 2 patients that had something pop up in the nipple. Now, that is very simple to see. You don't really need any imaging for that. We always teach patients that you still need to observe your breast. And if you see some change, you always want to alert your doctor. But with that kind of visual observation, I've really only had 2 patients that had issues. And
Amazing.
so you can imagine how many nipples we've saved over the years.